Hold up. Actually, let's just hold that conversation for now.
Yeah.
So where we left off last, Elena, we were talking about, we did the AV blocks, and then we compared AV blocks with block PACs. And I think this is where we left off, and then we're going to dive into a little deeper stuff here. Before we start, do you have anything you want me to go over again, or even not just you, Joanna? Do you want anything, or Kristen? Anything you want me to refresh you on before we continue on here?
Well, we talked about junctional with the P positive P wave.
Right, the possible WPW, which I didn't want to talk about here because we hadn't even got to that area yet, which I have a picture of it, and I'll talk about it a little bit tonight.
Okay, we'll get to that then. Okay.
Can you do junctions again? Sure. Let me pull up my pictures here. It's all kind of...
Joe, put your voice on there.
Yeah, Joanna.
Come
all
on.
friends here.
I'll get on video. Let me see.
I know, Jeff, you recorded the last meeting too, and I think you said you were going to upload it. So for my own reference, awesome. And then Joanna too, we did a great refresher and kind of review last video course too. So if you can find that in addition to today's review, that's a great resource too.
Yes, awesome. I did send it to her directly. It's on the YouTube. It's all time stamped too, so if you want to jump around. I need a picture of it. How did I do this last time? God, no, don't leave that. Oh, I'm not sharing my screen yet. Shoot. Share. There it is. Okay, that looks better. All right, so Joanna. So it all really comes down to the inherent heart rates of the heart. The upper chamber is a little bit faster, and the lower you get, the slower they get. The atrial chamber is between 60 and 100. The AV junctional area is between 40 and 60, and the ventricle is between 20 and 40. So what's happening is the normal pacemaker of the heart, the SA node, that depolarizes, and that wave of contraction comes down and depolarizes everything. And as it depolarizes the other cells below, it puts those cells in suppression where they've been used and can't be used again. If for some reason the SA node was to fail, the other cells in the atrial chamber hopefully pick up the slack. So that would be an atrial atopic beat, where you have some cell over here in the atrial chamber that fires. Oh, Kristen, what are you doing, Kristen? So the atrial chamber fires. You have a different P wave, but it's still going to be sort of positive and follows the normal pathway down through the septum of the Purkinje fibers. Now, if the SA node in the atrial chamber to fail, the junctional AV area, those cells have the action potential to contract and create a P wave and an impulse and fall down the same normal pathway. But with junctional cells, because they're the lower section of the atrial chamber, they also have to go back up to tell the atrial chamber what to do. So if we find some junctional P waves here, let's see that up there. Sorry, can't find the junctional stuff. Okay, close enough. Let's go this guy. So, because the atrial impulse is originating from the junctional area lower in the AV node, and that wave of contraction goes out, it has to go back up to tell the atrial chamber what to do, as it also travels downward to tell the ventricle what to do. So when it goes back up to tell the atrial chamber what to do, that is creating that negative P wave in a junctional. So to be junctional, the PR interval has to be less than 0.12. So a normal PR interval is between 12 and 20, 0.12 and 0.20. And it's usually positive. The P wave is usually positive in lead 2, or has to be positive in lead 2, because this junctional area is already, think of that P wave as travel time. It's not exactly, but it takes less time to get here. So that creates that shorter PR interval. And because it has to go back up, tell the atrial chamber what to do, it creates that negative P wave. So you see this negative little guy, it's less than 0.12. So that is junctional. So with junctional, you have 3, I'm going to draw this again. This is my 2-scale heart. So you got your SA node up here. And the junctional area encompasses a little bit of the lower atrial chamber and the upper ventricle chamber. So if the impulse of the junctional originates high in the junctional area, which is low in the atrial chamber, it's going to be just before the QRS complex. It's a terrible drawing. Just go with it. If it's happening someplace in the middle, it's going to be buried inside the QRS complex. You'll maybe see a little extra notching on the QRS. If it's happening in the low junctional area, the P wave is going to be retrograde. It's going to be just after the QRS complex, and then of course you have the T wave. So those are the 3 positions that you'll see of junctional. But to be truly junctional, it has to be less than 0.12 PR interval. If it's before, of course. If it's after, you don't need to measure a PR interval. And then the P wave has to be negative in lead 2. Because normally with your lead 2, anytime something flows towards a positive, let me actually bring up this guy again, the triangle. So lead 2 goes from the right arm to the left leg, and it flows towards a positive. So because normally a P wave happens in the SA node, and it leaves the SA node, atrial chamber, goes down to the ventricles, is flowing towards that positive, the left lower. That creates that positive P wave. Anytime something flows towards the positive, it has a positive P wave. But because the junctional area is a little bit lower than that, it has to go back up to tell the atrial chamber what to do. It's flowing towards the negative now, and that creates that negative P wave. So again, to be junctional, you have to be less than 0.12 and negative in lead 2. How's that for you, Joanna? And that is just normal. That is just normal junctional. Of course, you have like junctional attack, junctional escape, PJCs, premature junctional contractions, just like PACs.
Good.
You have a sorry.
Response.
So just
I'm trying to figure out how to work this.
Oh, you're perfect, Joanna. So what was I saying? So just like PACs, you have premature junctional contractions that are just excited cells in the junctional that just want to come first, so they're early. A lot of times we'll see PACs, and PJCs will look very similar to PACs because that excited cell happens, but then it follows that normal natural pathway down through the septum, through the Purkinje fibers, and it has a more natural looking QRS complex. So we'll see PJCs and sometimes just bundle them in with PACs because, when everything's squished together, you don't always get to see that obvious negative P wave. So it's a narrow QRS complex, so it's PAC usually, but sometimes it could be PJCs. This happens to be, so the inherent heart rate of the junctional area is between 40 and 60. This one here just has to be accelerated. So accelerated is 60 to 100. Anything over 100, then it becomes junctional attack. So this one happened to be, let's see if I can find a nice perfectly lined up right there. 300, 150, 175, almost exactly 75. So it's just a little bit above 60. So it's accelerated junction. This one above, the P wave is retrograde. You see the negative P wave right there, just after the QRS complex in lead 2. And of course, you have PJCs. This one, the QRS looks a little bit different just because it acquired a bottom branch block, but you still have that negative P wave right there. And it's early. You get a compensatory pause after the fact. Compensatory pause, that is just anytime after some ECG, PAC, PVC, PJC, things like that. That is just the heart saying, oh, something happened a little too soon. Let's just get back in line and then go back to the normal rhythm, regular rhythm. It's just a temporary little gap of time. More PJCs, you got a negative little guy right there, but then you have the same narrow QRS complex. How was that, Joanna?
Good.
Thank you. Okay, so last time we left off at AV blocks and parent AV blocks with block PACs. Yeah, let me look at the list here. So we did all the basic stuff, and I wanted to start to include some, it's not next level stuff, but really kind of noteworthy things. Like there's more to sinus than just, the old classic things. I'm just trying to have words here while I figure this out. So the sinus stuff, you get your normal sinus, Brady, tachyon, arrhythmia. But outside of that, you have sinus pause, sinus rest, and asystole. So for Phillips, which I think everybody here will use Phillips, per the machine's definition is a gap of time, because the Phillips machine is constantly measuring every R to R. It's saying, okay, this is what it usually looks like, and it kind of tracks that. So if you have an extra gap of time that looks bigger than what is normally happening, and if that gap of time is less than 2 seconds, the machine is going to call it a misbeat. And that's just a broad umbrella encompassing thing. It could be a bunch of things. It could be a secondary. It could be a block PAC. Many things. It could be just a PVC that is not seen on the picture. Like you could see it with your eyes, but the machine just doesn't see it because the amplitude's so small. That's happened before too. But if you have a gap of time that's less than 2 seconds, the machine will call it a misbeat. You can just be lazy and say, oh, they have misbeats, but you want to look into it. Why are they having misbeats? Is it a block PAC, secondary, things like that? But once that gap of time becomes greater than 2 seconds, the machine is going to call it a pause. So when we say pause, sinus pause, what you're saying is the SA node, the sinus node, is stopping, is pausing for a second, right? And when that stops working, what do we not see? We don't see a P wave. And then if no P wave or no contraction leaves the SA node, there's no impulse to go down and tell a ventricle what to do. So then you have no QRS complex. So you'll have a gap of time that's a little bit longer, and there's nothing in the middle. There'll be the last T wave or the last conducted beat. There'll be all isoelectric baseline until something else kicks in. So that's a sinus pause. And sinus pause, per the Phillips definition, is between 2 seconds and 4 seconds. After 4 seconds, the machine is going to call it asystole. Technically, asystole is the ending of all activity, be it atrial and ventricle. It's kind of weird because like it should go sinus pause, which is just a small gap of time, then sinus arrest, and sinus arrest is just a longer amount of time, but sinus arrest will come back, or something else will pick up the slack. That's where you'll get escape beats. So when you have a extra gap of time, that heart rate is going to start dropping. It's going to get to that junctional area where it's between 40 and 60, and hopefully a junctional cell will wake up and take over and do something. If that doesn't happen, the heart rate's going to drop to the 20 to 40 area, and then the ventricle has that opportunity to contract. So that's where you get those escape beats, where the heart rate's dropping, and the safety mechanism of those inherent heart rates kicks in. So that would be sinus arrest. The sinus node is stopping working, and at some point it will come back. Asystole is stopping of everything, nothing works. And you just have long gaps of time. And not to talk about this now. Then you also have ventricular standstill, where you'll see P waves, but there's no ventricular response. So you'll just see P waves marching out, and then no QRS complexes. Let's see. So sinus pause, asystole, and really we use asystole and sinus arrest. It's really interchangeable. Anything over 4 seconds, you're not going to sit there and nitpick like what's the difference. You're going to call a nurse and say, hey, you might want to check on this patient, right? And if for some reason nothing comes back, you call whoever your resource is and say, hey, things are happening or not happening in this room. So really, it's just more of a long rant than anything, the difference between sinus arrest and asystole.
What about agonal?
So agonal is the heart is trying to do something, but it just doesn't have the strength. So you'll see this just kind of like little wave of activity, but the heart is dead or dying, and it's just kind of contracting. So you'll just kind of see a little wave of activity. That's something different. What do you think, Kristen?
I think it's pretty much asystole.
Mm-hmm.
With a few, attempts to come back, but not. It's just basically muscles not working anymore.
Yeah, I mean, at that point, again, we're splitting hairs. Like we need to be making phone calls instead of talking about like the difference between that. We don't have beats that are perfusing blood to the body, and that's bad.
Mm-hmm.
Let's see. So one other thing in the sinus area I want to talk about is exit blocks. So where sinus pauses, the SA node is failing to work. With sinus exit blocks, excuse me. Does that go by? There. Okay. So the SA node is this group of cells up in the right atrial chamber, and it's made up of two types of cells. So inside the SA node, they're actually called pacemaker cells. It's this group of little cells, and those are what the potassium, the calcium, they all change places to make that electrical spark. So those are the pacemaker cells. But encased around those pacemaker cells is called the transmitting cells. And sometimes increased vagal tone, whatever it may be, the reasoning is those pacemakers inside the cell contract, make that spark, but are not transmitted outside through those transmitting cells to leave the SA node and then go down the normal pathway. So this is what you call a sinus exit block. So what's happening is if I had calipers I could use on the screen, you would see if I took 3 P waves, this would march out. And what that means is the SA node is contracting regularly at 83 beats per minute, and a P wave should be there. The SA node knows it contracted at that moment. Beyond that, its job's done. It could care less what happens. It's still going to beat again exactly on time. So with sinus exit blocks, you'll have this very regular interval of dropping. So what you do is you take 3 P waves and they should march out. They will march out. Because what this rings as is missed beat. So you look at it and go, okay, there's no secondary block here because there's no extra P wave. There's no block PAC, right? So there's no extra P wave heading inside the T wave. What else is it? So those are the big 3 things that you're going to see with small little blocks. It's either going to be a secondary block, it's either going to be a block PAC, or it's going to be an exit block like that.
I can zoom in too. Oh, that doesn't zoom in on you guys' screen, does it?
No, I just see a big hand.
Oh, okay. Sorry. I was zooming in to make sure there's no P in there.
I can do it too. That's awesome. I didn't know that.
Oh, can you?
Yeah.
Oh, good. Good. All right. So, and what I was just trying to show you is like what the 3 things you're going to see when you see a gap in time. This is generically just a misbeat per the machine, but we can look into it and do a little bit more and say, okay, what's happening? And just give the nurse a little bit more information. Was it a secondary? Was it a block PAC? Or was it a sinus pause?
And the 2 R to R's before the missed beat, those should, if you take those 2,
these guys,
actually 3.
Yep.
And take the calipers over to the missed beat, it should equal that distance.
Right. I mean, exactly, because it's still sinus, so you still have a P wave that's associated with a QRS complex. So what I do is I march out the P waves, but if you have a consistent P interval, the R is going to do the same thing, right?
Mm-hmm.
Because this P interval is consistently, this PR interval is consistent. So you can do P to P, you can do R to R, but like she said, this R to R is going to match out this R to R, or this P to P is going to match out this P to P. Same difference.
Okay. So what is the is there any it's just a sinus exit block. It's not really something, a
lot of times
what would it indicate?
A lot of times it's increased vagal tone. Whatever they're doing, they could be, remember those times where people are vomiting and they go into secondary blocks like that. It's kind of like that.
Okay.
Or they slow down. It's just that increased vagal tone that happens. And there are things, medications, things like that. But for this Zoom, we don't need to know that.
Okay. Emily's not here.
Yeah, she's out playing roller derby.
Okay, unrelated, but that's awesome.
Yeah, she's pretty awesome.
Yes.
So the atrial stuff that I wanted to go over. So normally, going back to the intrinsic heart rates, the SA node is between 60 and 100. The AV node is between, the SA node and the AV area. Wow. The SA node and the atrial chamber is between 60 and 100. The AV node and the junctional area is between 40 and 60. The ventricle is between 20 and 40. So if some reason the SA node is to fail, hopefully the atrial chamber picks up the slack. You'll have a different P wave, and then the heart rate may change a little bit. So we have an atrial topic. We have two different P waves there. What we can have is these are kind of bundled in with SVTs, but an atrial tach or PAT, proximal atrial tachycardia. It is just another form of SVT. It's when you see an obvious different P wave that suddenly puts the heart rate up above 100. So SVT, supraventricular tachycardia, right? So you have a sudden onset of narrow QRS tachycardia. And with atrial tach or PAT, you're going to see a different P wave, sudden onset, it's going to be above 100. Whereas sinus tach, it can come on fast, but it's like 90, 95, 100, 110, things like that. But with SVT or all these sudden onset things, it's going to literally go from 60 to 150 in one beat. So atrial tach, PAT, they're all kind of SVTs. What you're just going to see a different P wave, sudden onset of narrow QRS tachycardia. Question? Got a thought there?
Atrial tach. I don't like it. Atrial tach gets me all like, because flutter can sometimes look like atrial tach, it's like, I don't know, I don't like atrial tach.
It's just SVT.
With a block.
Right. So, all atrial tach is an SVT. Like all SVT comes from the atrial chamber. Right? No SVT ever comes from the SA node. It can't come from the junctional chamber, but 99% of SVT comes from the atrial chamber because that is the excited cell. Mm-hmm. Right?
Mm-hmm.
The excited cell in the SA node is never sudden onset. It can be sinus tach, but it's not an SVT. You got to have that different P wave though.
Yeah.
But like what you're saying, where flutter and atrial tach can look similar, there is a difference. So with flutter, there's a, I don't remember what it is, but there's a group of cells down near the tricuspid valve that contracts. And with a normal flutter, it goes counterclockwise, where it leaves that group of cells, passes the AV node, goes up the middle septum, across the roof, down the anterior wall, and then just does that cycle over and over again. And that's where you get that regular pattern. So let me clear this. Get it out of there. So with flutter, with that circuit that it does, that atrial activity is very regular, very fast. It's usually right around a rate of 300. So you get that sawtooth pattern. You never have any isoelectric baseline between flutter waves. It immediately transitions into another flutter wave, right? Mm-hmm. So where atrial tach, in that you never have an isoelectric baseline because flutter, the atrial activity of flutter is right around somewhere between 250 and 300. Where with atrial tach, the atrial rate is right around 150 to 200. So that slows that atrial rate down a little bit and allows you to see isoelectric baseline between the atrial activity. Like right here, you got two P waves. Yeah. And this here, Elena, is what you call an atrial tach with a block. So you get a P wave there, you get a P wave there. They all have the same morphology, the same look to them, and they march out very regular. And this atrial tach with a block, when we say block, we think of blocks as being bad, but in this case, it's actually good because the AV node is only letting half of these go through, and it's keeping the heart rate at a more manageable rate of 100 instead of 200.
So where in the block?
So the block is because this one doesn't have a QRS complex. Only every other P wave has a QRS complex. So that is the block part, right?
Minji.
Joanna still awake?
She said talk smack.
No, I'm sleeping.
Wouldn't pass it by you.
We need an image to
yeah,
that.
Joanna. Let me make sure you're awake.
No, you don't want to see me.
So atrial attack. Technically, it's not an SVT because the QRS doesn't go above 100, right? But there is something going on there. If all those P waves are creating a QRS complex, you definitely would just have a PAT. It would just be proximal atrial tachycardia or atrial tach. But this one is unique because it's atrial tach with a block. The AV node is stopping every other one from going through the televentricle into two. And I like this example because you can see the difference between atrial tach and flutter, where flutter flutter, that atrial activity immediately transitions into another atrial activity, right? It comes down, goes right into another one. Where that previous picture, you had isoelectric baseline between the two.
And then AFib is even more quivering of that baseline, not like the ATAC.
Okay. So both of atrial tach and flutter, it's a very organized contraction where there are excited cells with these ones, even though they're inappropriate and ectopic, but they're very not conformed, but they're very regular. Where AFib, let me see if I can find a picture of AFib. AFib, the atrial chamber is literally in a muscle spasm, right? It's been overworked through the years, and it's just kind of quivering. And I'm getting there. Hang on. Right here. So all this roughness along the isoelectric baseline, that is just the atrial chamber just in a muscle spasm, just quivering there. And these can be up to 800 beats per minute. And the AV node is blocking most of them, right? But because of that quiver is very irregular, the responding R to R's can be very irregular too, because it's responding to the irregular nature of the atrial chamber, right? Where with flutter, the atrial activity is very regular. Atrial tach, the atrial activity is very regular. Even though it can be sometimes irregular atrial flutter, it's usually with a pattern where it goes 2 to 1, 2 to 1, 3 to 1, 2 to 1, something like that. The variable conduction. Sorry, I'm just kind of jumping around.
Sometimes fib can be confusing because you can have coarse AFib as well.
Absolutely. And this is actually an example of coarse AFib. And like she was saying, like if you were just to look at these like 3 atrial activities right here, you're like, oh, that's flutter, right? But that atrial activity of AFib, it's going to wax and wane. It's not going to be consistently the same amplitude, the same strength, the same morphology, because you fall it over and it just kind of smooths out over here. And that's just the spasm a little bit stronger, a little bit weaker, and irregular. Where the activity of flutter, the amplitude of the atrial activities can be very consistently the same size and very regular to itself. And so, like she was saying, coarse AFib at times can look like flutter, but you're going to see this totally irregular R to R, and you're going to say, why is this flutter irregular all over the place? It's not flutter, it's coarse AFib. And while we're right here, we got fine AFib. We get no P wave, just a little bit of roughness along the baseline, and that is just the atrial chamber just not as strongly spasming. Yeah, let's see. Yeah, I can't remember if we talked about wandering atrial pacemaker. So atrial atopic, you have two different P waves. You have one P wave coming from the SA node, and then you have another P wave coming from the atrial chamber. I wish I need like little slides that I could just click on.
Yeah, I know. And you need calipers. Where are your manual calipers? Well, you couldn't hold them up to the thing anyways.
Wait, where is it? Right there. So a wandering atrial pacemaker is going to be 3 or more different P waves, where atrial atopic is 2 P waves, one coming from the SA node, one coming from the atrial chamber. In a classic wandering atrial pacemaker, there's going to be a consistent cycle. What's happening is the SA node is going to do a sync for a couple beats, then the atrial chamber is going to do a sync, and the junction is going to take over. So what you'll see is a positive P wave, sort of flat in between P wave, and then you're going to see a negative P wave. That is a truly classic wandering atrial pacemaker. So you can see right here, you have like positive through here, it goes flat right here, and then you're negative over here. So with a true classic wandering atrial pacemaker, it's competing pacemaker cells. It goes SA node, atrial chamber, junction, and you'll see the cycle of going back and forth. But saying that, sometimes it just can sit in one of those P waves for a long period of time. You can say, oh, that's just junctional, and then they'll come out of it. When the bigger picture, yes, in that small little burst, it is junctional, but the bigger picture, it is a wandering atrial pacemaker. Again, splitting hairs. You can call it junctional, whatever. It's not sinus anymore. That's the big thing. And there's another one that we bundle in with wandering atrial pacemakers is multifocal atrial rhythm. What this is instead of that consistent cycle of SA node atrial junctional, it's just kind of coming from all over the places. There can be no rhyme or reason. You'll definitely still see 3 or more different P waves, just like wandering atrial pacemaker, but there's not going to be that pattern. Like, for instance, all of these are positive, but look all the different morphologies. This one's like flat, this one's pointy, this one's still pointy but a little fatter. So. All right, so let's block PACs, fine, coarse, paroxysmal AFib. It's just short bursts of AFib, where instead of the patient just converting to AFib and staying in it, it'll go in and have a run for like a couple hours or a couple minutes or whatever. It's easily, I don't want to say that. You're just going to see this. It's another form of SVT. Anything sudden onset of narrow QRS tachycardia is an SVT, and AFib is generically an SVT, because when they convert to SVT, they tend to be very fast, and it's still going to be a narrow QRS because it still comes from the atrial chamber, goes down through the AV node, through the bundle of His and the septum, and goes out through the Purkinje fibers. Even though it is generically, broadly speaking, an SVT, we have a better label because we're going to look at it and say, all right, there's no P wave anymore. There's just fibrillation along the baseline. And then there is no regularity to the R to Rs. So saying all that, paroxysmal AFib is just short little bursts of AFib. It'll come and go. Like, you got sinus down here, you got AFib up here. That's all you're going to see. kind of just jumping around here. You guys, any questions before I continue? Joanna? Make sure she's awake.
I'm all good.
Okay. Elena, any questions so far?
I think I'm good. You would tell the nurse if they're an AFib in any way?
Oh,
Would you like
absolutely.
to?
You see this
Okay.
and say they just had a short run of AFib. If you want to keep it simple, and they just had a short run of AFib that was 4 minutes long, and they're back to the normal sinus. Or they just converted, and then they convert. As soon as you hang up the phone, you have to call them back. They're like, all right, they just converted back to sinus. Like, just keep
Okay.
communicating with the nurse. Yeah.
Yeah.
Yeah, they just love it when you call them like 15 times.
And make
I'm
sure
like,
you send them strips. All
that's
of them.
right.
Dozens
I
and dozens
do.
of strips for them to sign off.
Every darn one of them. No. Pretty much. But,
I'm a better safe than sorry kind of person. I'm gonna
yeah.
give you over information before I give you too little.
I always said, like, if it's worth a phone call, it's worth sending a strip for them to look at. If you're going to tell them something, give them something to look at, unless it's the same thing 4 dozen times. Like, and here we don't even print down here. We don't even print strips anymore. We send it electronically directly to the chart, and you'll say, "Do you want another copy of this?" I'm like, "Nah, we're fine." Okay.
Yeah. Wow. Wow. So they're ahead of us on that electronic charting.
Yeah.
Wow. I don't know how I feel about that yet.
I have mixed opinions because I actually no longer have the capacity to print out papers in my office anymore. So I can't collect all these cool little things anymore.
Yeah. Oh, that does stink.
Yeah. All right. So RVR, rapid ventricular response, is, I think it was right here for a second. My opinion on RVR is, first of all, when you convert to AFib, you're going to be fast and uncontrolled. Anything over 100 is going to be considered uncontrolled. And because the atrial chamber is in a muscle spasm, and it's usually, that spasm can be at up to 800 beats per minute, it's going to be fast. The responding RR is going to be fast. You'll see people convert to AFib, and they'll just see 130s, 140s, and that's who they are. People will say that's RVR. And what that stands for is rapid ventricular response. But I think that's their norm. That, in my opinion, that's their norm. For me, RVR is the even faster little bursts inside of AFib, like right here. So you got AFib down here, but you got these little bursts of AFib. And sometimes they could just maintain that. Like if it gets to the point where they're maintaining 150s, 160s, 170s, yeah, you can call it RVR. Or, yeah, I don't know. Depends on who you ask on this question. I got thoughts on this.
So can you do flutter? Can you get flutter with RVR?
No. You're going to have a variable conduction. You could be a 2-to-1 flutter. This could be 150, and that's just a better label. You're just going to say their flutter is 150. 2-to-1 flutter is 150. I think that's a better label for a fast flutter. Or you don't want a 1-to-1 flutter. That's 300. So
yeah. So if you're in flutter, then it's going that fast. It's just the conduction, not that they're rapid ventricular.
Right. I mean, you're splitting hairs at that point because they are responding rapidly to their ventricle is responding rapidly, but it's more because it's just a 2-to-1 flutter. I think that 2-to-1, if you call in a 2-to-1 flutter at 150, sorry, if you see a flutter that's 150, I think a better label is just a 2-to-1 flutter. Okay. I think people are just more accustomed to that.
Mm-hmm. Okay.
I'm jumping around. I'm sorry. Did we actually talk about SVT last time, Elena? I can't remember.
I know that I have some notes on it, so I think that we did. I'm not sure how in depth we went. Let me see.
I don't think it was too much. Did I talk about it?
Yeah, I have like some notes, but I'm an over note taker too. So
Yeah.
we can
And
retouch if you want.
SVT is just this broad umbrella term that covers a bunch of things like we just talked about. It's what it means is supraventricular tachycardia, supra above ventricles tachycardia, and that you're going to see a sudden onset of narrow QRS tachycardia. Anything that's above the ventricles, any impulse originating above the ventricles could be a narrow QRS complex because that follows that normal natural pathway down. Where if that that contraction comes strictly from the ventricles, it's coming from that bigger, muscly part of the ventricle, the heart, the ventricles, and that's where you get that bigger QRS complex, right? So, broad umbrella term SVT, narrow QRS tachycardia, sudden onset. So you have some subgroups of that is, like we talked about a second ago, is PAT, proximal atrial tachycardia. And that, what you're saying there is, again, you have a sudden onset narrow QRS tachycardia, but you can clearly see the previous P wave that's probably from the SA node and the new P wave that's coming from the atrial chamber. So that's PAT, proximal atrial tachycardia. You also have what's called an MAT, multifocal atrial tachycardia. And what that means is it's going to look very similar to AFib, because what you'll have is 3 or more different P waves that are excited. And I do remember this. We talked about the difference between wandering atrial pacemaker and MAT. A lot of times we'll just say a fast wandering atrial pacemaker is an MAT. There is a nuance there, but we don't need to go down that road again. But with MAT, again, sudden onset of narrow QRS tachycardia, but there's going to be 3 or more different P waves. Each little P wave has its own little inherent heart rate, even though it might be normally between 60 and 100. One might be 111, one might be 137, one might be, whatever. So with that, each inherent heart rate, you're going to see a heart rate fluctuation. So there's going to be irregularity to that R to R. So MAT can look very similar to AFib. Saying that, where when it's really fast, all those impulses are bunched together, and you're not always easily able to see that P wave in there. And then when you do, it's going to look different, and you could just say, it's AFib.
Is MAT a WAP over 100?
It's not, Joanna. And I know we said that for a long time, but a wandering atrial pacemaker, it's ectopic pacemaker cells, where the normal pacemaker cell of the heart is the SA node, and then with a wandering atrial pacemaker, it's competing pacemaker cells, where you goes from SA node, atrial chamber, junctional. Those are pacemaker cells, where PACs are excited cells. So then you have an MAT, they're all excited cells. And that's the difference, the nuance between pacemaker cells and excited cells. So the wandering atrial pacemaker, just because it's above 100, I don't want to say that. It's more they become excited cells. There is a difference between a wandering atrial pacemaker and an MAT, because wandering atrial pacemaker are ectopic pacemaker cells. MAT are excited cells. So, I'm sorry, I kind of bundled that or jumbled that one up.
Hold on. WAP, ectopic pacemaker cells, and then MAT is what?
Excited cells. Just like a PAC is an excited cell. Like, it's kind of the difference, like in atrial ectopic rhythm, right? You have 2 different P waves, where one's coming from the SA node, one's coming from the atrial chamber. You're not going to call that PACs because they're not excited cells. Where a PAC, you're going to have an early P wave, early QRS complex. Those are excited cells.
Okay.
And Jan and I had this conversation for many years. Like, we should create a label of accelerated wandering atrial pacemaker, because you have these moments of like the wandering atrial pacemaker not being excited, but is just a little bit on the faster side. It just kind of flirts with that 90 to low hundreds area. And we're like, oh, let's call it a accelerated wandering atrial pacemaker. We're just making up shit, really. Accelerated wandering atrial pacemaker. But there is a difference, even though we bundled the two together. And for ease of use, just keep doing that. It's fine. Mm-hmm. But there is a difference between pacemaker cells and excited cells. So technically speaking, calling an MAT is not a fast WAP.
All right.
Long-winded answer. I gotta go potty real quick. Hang on.
Okay. Oh, Jeff.
And he's recording this.
Oh, shoot. Maybe he can delete this part out. That's funny. Joe, put your face on here. What are you doing?
No, I'm in my pajamas.
I'm in my Send it to my phone.
No.
Are you wearing your, like, do you have a character on your pajamas?
No. I'm not describing this. This is weird.
I'm in my pajamas.
Hello.
Welcome back.
You'll have to delete that part of the video.
Oh, did you hear that?
What?
You didn't hear me, did you?
No.
Okay. Jesus.
No,
like I swear I muted myself.
You got scared.
Oh, shoot.
So SVTs.
All right, let me go
SVT is just a bunch of PACs in a row, right? Instead of one excited cell happening once, it's happening a bunch of times. You can have a short little burst, 3 or 4, you call it a salvo. Usually we don't call it SVT until it hits 3 seconds or more. And that's 3 seconds of those fast PACs all grouped together. And inside of SVTs, you got that PAT where you can clearly see a different P wave. A lot of times you won't. And just generically calling it SVT is fine. MAT is going to be regular, but you can still see 3 or more different P waves. And those are SVTs. So really, SVT is just a bunch of PACs in a row. I don't want to talk. Go ahead.
Usually, for SVT, true SVT, I usually will say if I can't see the P wave, because it's like buried in the T, then I'll call it SVT. But if I can see a P, then I'll call it PAT.
Yeah, exactly.
Paroxysmal atrial attack.
Yep.
Okay.
WPW, I don't really want to talk about.
Okay.
It's just extra.
Yeah.
So we talk about excited cells wanting to come first, like PACs, PJCs, and PVCs. And real quick, PVCs, all VTAC is a bunch of PVCs in a row. Just like SVT is a bunch of PACs in a row, all VTAC is a bunch of PVCs in a row, right? So these are all excited cells. So there's also stuff called escape beats, where this is the safety mechanism of the heart, where that heart rate is dropping and it's going down through the chambers, where instead of 60, 100 failing in the atrial chamber, 40 to 60 the junctional area, and then the 20 to 40 the ventricle area. So as that heart rate drops, all these cells have that action potential to contract. These right here, what you call ventricle escape beats. The junctional didn't pick up the slack. And first of all, it's eighth bit. So there's not really an opportunity for atrial atopic, because the atrial chamber is just in a massive muscle spasm, or atrial escape beat, that is. The junctional area didn't pick up the slack. So that heart rate drops. You can see that the R spreading out. And then that wide QRS complex comes in. And that's what you call an escape beat. This one just happens to be a ventricle escape beat because you have that bigger, wider QRS complex versus these guys over here. And these are good, because if these didn't happen, no other beat would come in, right? These are not like bad like PVCs. I mean, maybe they have something else going on, but this is the safety mechanism of the heart. Escape beats. This is an interesting little SVT. If you were just to see this down here, you're like, oh, this is a wide, fast rhythm. Let's call it VTAC. But is this QRS morphology any different than the normal beat? These are the normal beats over here, because you know that you have a P wave and a QRS complex. Is this QRS any different than this QRS? Same exact QRS, right? It's just sped up. So this is still just SVT, even though it's wide. It's SVT with a bundle branch. Where if you look up above here, see these guys are so much bigger than these guys. These are actual PVCs. See how much bigger that is than this guy? So a lot of times when you see something roll by, does the QRS morphology look any different? This one, it did. It's just the same QRS complex coming through faster. This is an MAT, like we talked about. You can see the irregularity all through it. You look at lead 2, you want to look at the atrial activity. You can kind of see these P waves down in here, and they're all kind of different through here. But it's irregular. It's all kind of all over the place.
So wait, that one, what did we say about multifocal atrial rhythm? Sorry. Yeah. So
this multifocal atrial tach is above 100.
Okay. And then what's the multifocal atrial rhythm once again? Sorry.
So that's below 100.
Okay.
And it looks very similar to a wandering atrial pacemaker, but instead, where the wandering atrial pacemaker has that cycle of SA-do atrial chamber junctional, it just has a sporadic P waves all over the place.
Okay.
So you still have 3 or more different P waves, but it doesn't follow that cycle of positive biphasic flat and then into a negative, where that with a wandering atrial pacemaker.
Okay.
So this is a lot of stuff that we already talked about, but I am getting to ventricle stuff. So like we said a minute ago, PVCs, premature ventricular contractions, they're excited cells in the ventricles that just want to go first. So you have a bigger, wider QRS complex. It's early, a little compensatory pause after the fact. And then VTAC is just a bunch of PVCs in a row. Instead of one, you get a bunch of them. idioventricular. So here's the difference again between excited cells, like PVCs are excited cells. Idioventricular is an atopic pacemaker in the ventricle. So what you see with idioventricular, there's going to be a slight gap of time and delay before that wide QRS complex comes in. So it is an atopic pacemaker in the ventricle that just wants to take over. A lot of times we'll see idioventricular after a patient has had an MI or some sort of a occlusion in the heart muscle. Oh my God, excuse me. So when that damage happens in the heart, it is deprived of oxygen and kind of dies. Once that heart cell starts to get reoxygenated, that cell can come back alive a little bit. And then that cell is just like, oh, I need to do something. And it starts contracting. And that's where idioventricular normally comes from, is that cell waking up again after not really an full-on MI, just could be just a little occlusion. But anyways, it's an atopic pacemaker. It's just that cell coming back alive, and it just decides to contract to kind of get working again. So instead of fast and early like PVCs and VTAC, you'll see this slight delay and then into a wide QRS complex. Very regular. You ignore these guys down here, you got some PVCs, but we're just looking at this top stuff right there. So that's idioventricular.
And normally you won't see a P wave in front of it.
Yes, exactly. Right. All right. So the stuff I wanted to talk about is PVCs and bundle branches. So you have two ventricle chambers. You got right and left, right? So you can have excited cells from the right chamber and the left chamber. When you're looking at atrial activity, you want to focus on lead 2 when you're looking for those morphology changes. When you're looking at the ventricle activity, the QRS complex, you want to use the V lead. So, and this comes down to the importance of the placement of the brown lead. You know, the brown lead sits on, I don't know if you can see, sits on top of the right atrial chamber. It sits on top of the right ventricle chamber, which is fourth intercostal space down from the collarbone on the right side of the sternum, and that sits right on top of the right ventricle. So what's happening in the brown lead, like let's go back to. So the brown lead is unipolar. So sitting right on top of the right ventricle, it doesn't use any other leads. It just uses itself. So the lead itself is positive. As that contraction goes towards the brown sticker on the chest or away from the sticker on the chest, you get that positive or negative action. It doesn't cross it, if that makes any sense. So that's what the importance of the lead placement of the brown lead is important.
Huge.
So this is what you call multifocal PVCs. Looking at the V lead, you have some negative and positive. When it goes below the baseline, positive T wave, that's a right PVC. When it goes straight up off the baseline into a negative T wave, that's a left PVC.
So someone I know was under the impression that multifocal just meant different shape PVCs. Like it doesn't have to be positive and negative.
So there is a slight there is a difference between polymorphic VT and multifocal VT, where I've always just used the same. So monomorphic is you have one morphology of the QRS complex. Polymorphic, you have multiple morphologies of the QRS complex.
Mm-hmm.
Multifocal means is coming from different areas in the ventricle chamber. So polymorphic is you can have polymorphic VT from just solely the right chamber, and all those QRS complexes will have varying degrees of morphology amplitude, and that could be simply in response to conduction down through, or there's multiple different reasons. Where multifocal is purely coming from left, right kind of thing. Where back to this example where positive, negative. So that there is a difference between polymorphic and multifocal. Polymorphic, you could have, well, like torsades. Torsades is a very specific form of polymorphic VT.
Mm-hmm. That's my book. Oh, it's over there.
Something you want to talk shit about?
No. I'm good.
So let me find
multifocal coming from multiple foci, right?
Yes.
Is many forms. So it could be.
So I'm getting a little ahead of myself, and I want to talk about bundle branches first before I continue on with this.
Yeah.
So normal impulse, leaves the SA node, depolarizes the atrial chamber, gets to the AV node, comes down through the bundle of His area, and down through the septum, the Purkinje fibers, and contracts the ventricles, right? So bundle branch blocks. You have two major left ones. You got an anterior and posterior on the left, and then you got an anterior on the right. And this picture doesn't really show them. It just kind of shows this like little shoot off here. So with bundle branch blocks, what's happened is there's been some sort of damage that, and let me back up. So the bundle branches are electrical pathways for the impulse to go down to make the ventricles contract in a very unified regular contraction, right? It's very synchronized little contraction. At some point, there's been some electrical pathway blockage. Whatever the episode that happened, this guy now has a little bit of blockage in one of those electrical pathways. But that impulse is still trying to get down there. So it goes around that blockage. Like, so for instance, this posterior left, instead of going down the normal pathway, it's just going to go around that blockage and then get in the normal route, right? So a normal QRS complex is between, 0.06 to 0.12. So if you think of this detour, just like when you're traveling down the interstate, you get a detour or delay, you increase your travel time. So a bundle branch block is going to be greater than 0.12 QRS complex. Okay? So you're going to have a wider QRS complex. So saying that, sorry, where are my bundle branches?
think you had more of them at the beginning, didn't you? Way back. Oh.
Degrees. So, all right here.
Oh.
All right. Okay. So a left bundle branch block. So this rhythm is AFib. So beyond the point that it's irregular, you're going to see that big wide QRS complex, right? So when you're looking at bundle branch blocks, left bundle branch blocks are going to be negative. And this is purely tele specific. You know, technically speaking, you need a 12 lead to truly say it's a left bundle branch, because in V6, it's going to be opposite of this. It's going to be a positive QRS in V6, and there's going to be a Q wave in the one lead. But just for tele, this is what we're going to say. If it's below the baseline, it's going to be a left bundle branch block. It's going to have a positive T wave. And this is V lead only.
So, I heard that one other time.
Say again?
I heard that one other time, but I'm...
Heard what?
With the positive T wave thing. Someone else said that too. I'm just kind of like, are you supposed to measure the nadir? Or in AFib, you can't really do that because of...
Well, no, you can measure the nadir on that. I mean, we haven't talked about that yet, but you can see the rapid downward stroke, and it's very quick. Yeah. And the nadir is, the beginning of the QRS complex, the bottom of the QRS, the R wave.
Okay.
But let's keep it separate right now. Those are lefts. If it's a negative in the B lead and a positive T wave, it's a left bundle branch block. With right bundle branch blocks, you're going to have a negative low dip. The last half of the QRS complex is going to be positive into a negative T wave, where left bundle branch is positive. So right bundle branch blocks has this biphasic, sometimes triphasic pattern where it goes negative, positive.
With a little septal activity.
Sometimes.
Mm-hmm.
So, and this is my old handwriting, but B lead only, we're going to compare bundle branch blocks to PVCs. And this is where it can get confusing, because like that example of SVT that was wide that we showed a little bit ago, sometimes you'll have SVT with an aberrancy, what it's called, and that SVT is just a wide QRS complex. So now you need to decide, is this a bundle branch block or a truly ventricle in origin? So using V lead, a right bundle branch block is going to have this biphasic pattern, bi or tri. So the septum activity can be there, doesn't need to be there. It's going to go negative below the baseline. It's going to go positive into a negative T wave, or a straight negative, positive into a negative T wave. Where left PVCs, again, you can have a little negative septum dip, but usually it's straight up off the baseline, slur on the downward stroke. It's going to be grossly wider into a negative T wave. Where with a right bundle branch block, it's going to have a significant negative dip first.
Are the PVCs gonna always have like notching on the right side or the left?
Not necessarily, but you are going to see a significant wider QRS complex where between right bundle branch and left PVCs, I feel like it's pretty easy because you're going to have that first negative little dip that's quite pronounced, where left PVCs is solely straight up off the baseline. They're going to be quite wide into a negative T wave.
Okay.
These two tend to be easier to tell the difference. Left bundle branch blocks versus right PVCs, this is a little bit of nuance. So with a left bundle branch block, you're going to have a very rapid downward stroke on that QRS complex. That rapid downward stroke tells you that impulse is coming down through the normal natural pathway of the septum and through the bundle branches, and then getting to the Purkinje fibers and the ventricles. Where right PVCs, there's going to be a slur on the downward stroke. What that tells you is that activation time is taking longer because it's coming straight from the ventricles. That bigger muscle mass is taking longer to depolarize. So what this is called the nadir. You're going to measure a QRS at the beginning of the QRS like you normally would to the downward point. This line right here is the measuring of the nadir. We were always taught if it's greater than 0.065, it's going to be in ventricular activation, where with the left bundle branch block, it's going to be a very rapid downward stroke. It's going to be a smaller number. Because with the measuring machines, you don't get to see that third digit. I just go for 0.7 and err on the side of caution.
Mm-hmm. Yeah.
Lena, what'd you think of that? There's a lot right there.
It is. I can definitely see the differences, and that makes sense with the nadir, but I also am like planning to look back and see exactly what it's the measuring of the dip. I guess, could you repeat what the nadir is again?
Sure.
I'm with you,
Yep.
but
So when you measure the nadir, you're going to measure, like I'm looking at my pointy top right there. Just as the activation of the QRS leaves the baseline, you're going to put one line there. And when I say line, I'm talking about the electronic calipers, right? You're going to put one line, and I know we haven't got there yet. We're going to put one line at the beginning of the QRS, and then the other line at the bottom point of the R wave, right down here. Where normally your full QRS measurement would be all the way to the end of the QRS at the beginning of the T wave. We're measuring the downward point. We're measuring the activation time of the ventricle.
that makes sense.
This will be a lot easier sitting next to me, and we've got people to compare to. Let me go back over here. So like this left bundle branch block. So you're going to compare left bundle branch blocks or right PVCs. You see how this activation time is very rapid. This downward stroke is very quick, right?
Yeah.
That's a left bundle branch block. Where are they? Someday I'll make this a little easier. If only I had a wife that was good at PowerPoints.
She can't be good at everything. She's already
it's awful, right?
Pretty perfect, you know.
Okay. So
The curvature.
you see, this is going to be a right PVC or a right ventricular tachycardia. You see this slur on the downward stroke? See that little notching? The notching,
Yeah.
This one's super obvious where you see that notching, and that's that delayed activation coming from the ventricles. But what we're really truly looking at is the nadir in measuring this time rate. If we're actually able to measure it, that number is going to be greater than 0.065 because of that slur on the downward stroke. Where that left bundle branch block, it was just a very rapid downward stroke. But honestly, if you're new and unsure and you see something wide and fast come through, just tell the nurse and then talk to your resources sitting next to you, and hopefully you guys can figure it out. Err on the side of caution and say they had a fast, wide rhythm come through. Let me send it to you so you can look at it too. And these little things that I'm talking about right now, I don't expect you to remember them right now. This is something you're going to have to spend weeks in looking at and talking about. Where this left PVC, this left VTAC, see how it's straight up off the baseline? And left PVCs, I think they're very pretty because they all go positive. Like with left ventricular activation for some, because it all goes towards that brown lead. So they're all going to be positive.
And wide.
Yeah, wide, of course. Sorry. Yeah. Thank you, Kristen.
And sometimes regular. Most of the time, you'll see regular with it.
There should never be an irregular VTAC, because R is irregular because it's usually responding to the irregular nature of the atrial chamber, right? If the patient's in AFib, you're going to have irregular R. Now, saying that, can there be a heart rate fluctuation where the VTAC starts out a little slower at 120 and then picks up to 150? So it's like a little bit wider R and then it squeezes it together. There's a rhyme or reason to that irregularity. But for the most part, VTAC should be very regular because that is an excited cell of the ventricle that is just contracting a very regular pattern. It's not, you could care less about the irregular nature of the atrial chamber.
Okay. That's a bad one right there.
Yeah, torsion. It's just another form of VTAC. Now, let's go to actually I can just do this the hard way. Get out of there. So on that Google Doc, there's a couple links that are handy. One of which is the SkillStat Lab. Excuse me. So there's two forms of this little game, and you can play the game or you can do the learn side. If you just want to learn, just hit OK, and it's going to show you the different rhythms. And what I want you to do here is just get used to that mental little checklist in your head of like looking at rhythms all the same way every single time. Is the R to R regular? Or is the R to R close together, wide apart, be it fast or slow heart rate? Is there one P wave for every QRS complex? Is the P wave morphology in the same on every P wave? Is the PR interval the same consistently? Is it in the same place before every QRS complex? And if you just let it go, it's going to give you this little, right? And, you know, that looks very regular. The heart rate looks good. So we're going to call it sinus rhythm. Sinus. Oh, we didn't talk about pacers. I'm sorry.
Might have touched on briefly last time.
I am just going to stop this real quick.
But that one does have a pacemaker.
Yeah. Just shut up. So I'm just going to briefly go over pacemakers. There's a lot to them, but for the most part, what we're going to see on telemetry is 2 pacer spikes, right? 1 pacer spike is, and really, you're looking for the muscle activity, the muscle response after the pacer spike. You have this pacer spike right here. What's after the pacer spike, right? What is that little bump right there, Elena?
The P wave.
Right. So this is what you call an atrial pacer spike, right? An atrial pacer. So then you have this P wave. The muscle response after that is the QRS, and that is a ventricle pacer. So you have AV pacing right now, atrial and ventricle pacers. And then look at that, it says right there in red. So in the pacers, they're all on demand, right? It's all what the heart needs at that particular moment. Sometimes it'll be atrially, sometimes it'll be ventrally, and it can interchange constantly. For pacers, the goal is for the natural pacemaker of the heart do as much work as it can by itself. And the pacer is just there to pick up the slack. Sometimes people need more pacer help. Sometimes people need less pacer help. So don't be surprised if you see it's all over the place. It's doing its job. As long as the heart rate doesn't go too slow or too fast, it's doing its job. There are times where failure to pace, or where you'll see a long gap of time, and where you think, all right, that heart's way too slow, because normally a low rate of a pacer is going to be 50, and this is 20s right here. So this is a pacemaker failure to fire.
You said low pacemaker rhythm is 40?
50. 50 is usually 50 to 60, yep. So this one here is the pacemaker failing to capture. The pacemaker up here, the pacemaker failed to work. This down here, the pacemaker is actually trying to fire, but it does not capture and make that tissue contract, right? Because you have the P wave, you have the pacer spike, you have a missing QRS complex as a failure to capture.
That makes sense.
Yeah.
I had a pacemaker the other night. It was pacing, but they were also having a lot of PVCs, and the pacer spike would come in the T wave after the PVC. Is that a fusion beat, or is that pacing wrong?
The pacer spike comes in say that again, Joanna?
The pacer spike, so they were paced, but they were also having a lot of PVCs, and the pacer spike was also coming in after the PVC in the T wave.
I'd have to see it. It's all about timing too. It's waiting for AV delays or activity to happen, and then it waits this milliseconds before something else happens. It could just be bad timing. I'd have to see it.
Yeah.
But to her point, fusion beats. So over here, so you have a ventricle pacer spike. Over here, ventricle pacer, that is. And because that pacer is directly in the big muscly part of the ventricles, anything coming from the ventricles would be a bigger, wider QRS, just like a PVC, right? So you can see the morphology of the QRS change through here. These are what you call fusion beats. So the intrinsic natural rhythm of the heart's coming through. The heart rate's picking up a little bit, and the pacer's still trying to work, but you're not getting that wide QRS complex. You're not getting that big wide contraction because the heart rate's already started to contract. You can't contract on top of contraction. So this is what you call fusion beats, where the pacemaker is trying to do something, but the intrinsic natural rhythm of the heart's already started. And really, that's all I want to talk about is pacers: atrial, ventricle, and fusion beats, and failure to contract, failure to capture, and failure to pace. That's the main stuff that you really need to know and remember. Kristen?
Oh no, I was thinking of one I had too with the T wave. It just kind of like widened out, and it worried me because I had seen one previously with the QRS widened right out, and that's when the patient basically they went to CCU and there was something going on.
Mm-hmm.
So
I don't know. I don't know what to tell you on that one. You're not gonna cry, are you? Jesus, can't handle that. Yeah, there's if when you sit next to me, Elena, there's much more we can talk about, but that's the main stuff we can talk about for now. So let's go back to this game.
That sounds good, and I love your optimistic thinking that I'm going to be right next to you. Thank you.
Yeah, when are you going to be
still
there?
Oh no, I hope. I know, and good for you for looking for, bigger and better Jeff with your classes. So I hope you do go
We'll see.
eventually.
I've already got declined for one job.
Oh, what?
It's so dumb. So 3 weeks ago, so I applied. I had my first interview, and it went good. And the woman was like, "Okay, so our court. I want you to talk to some potential peers to see if you're a good fit for the group." Like, sure, yeah, just give me their information. And she did like the email connections and this is this, and just keep in mind, this week and next week the quarter's closing and everybody's really kind of busy. So if we don't get back to you soon, that's because. So I'm like, all right, cool. 3 weeks go by, I don't hear from anybody. So I sent another email and say, hey, I'm still here, I'm still interested. And this got me salty. I'll tell you what. This what.
Are we still on the thing? You better.
Okay.
Better do that after.
Yeah. All right.
Oh, just like you told me, don't be discouraged. Keep on trying.
Yeah, that's right.
Take my own advice. So, anyways, the game, and it just this might be seem very simple, but just kind of look at it and get in that habit of like using that mental algorithm that you have and breaking it down. Is it fast or slow? Is it regular? Is the QRS is wide or narrow? And you throw things in like this, like, okay, just looking at it, it's irregular, right? It doesn't have a regular pattern to it, right? And can you pick out the irregular areas? And really what stands out to me is the compensatory pause, this gap of time right here. So that tells me, all right, something else is happening. Yeah. So you look at this R to R, how it's a little bit tighter. The R to R is a little bit faster compared to over here where it's a little bit wider. And it's not as obvious, but the morphology of the P wave is a little bit different, right? This one's a little bit more pronounced. This one's a little bit narrower, I guess. You get a compensatory pause, but it still has that narrow QRS complex. So you have an excited cell from the atrial chamber, comes in first, compensatory pause, what you want to call those sinus or PACs, right? Irregular, no rhyme or reason to it. Do you see any atrial activity? Sure, there's atrial activity, but is there regularity to the atrial activity, or is it just kind of a spasm all over the place, right? It's kind of a spasm all over the place. So you have that irregular nature of the atrial chamber. You have an irregular responding QRS complex. So AFib. Atrial flutter. See how that R to R is very regular because it's responding to that very regular pattern of the atrial chamber in the flutter. So this is kind of fun just to sit there in your spare time and just kind of look at and just get, And it's not so much about the rhythms, it's getting that used to that muscle memory of looking at rhythms the same way every single time.
Looking at it and also asking the questions, like, does it have P waves? Does it have a regular R or irregular? Are the beats wide, or
Yep.
And training your eye to recognize and pick up on those things in cahoots with asking those questions, like training your eye or just exposing to seeing it,
Yep.
All right, Joanna, this one's for you.
Still awake, Joe?
They're going to die by the time you answer, Joe.
Hello. What?
So fast, wide rhythm, right? It's a very wide QRS complex. It's very fast. You can see. Yeah, thanks, Joanna.
Sorry, my mic was it was delayed.
Dead.
I can't be under pressure like that.
But we are.
Elena. Very regular. Heart rate's decently controlled, but the QRS is very wide, right? But then you have that little spike before the QRS complex.
Does that have to do with the pacemakers?
Yeah. Okay. Normally on a telemonitor, the pacer spike will be highlighted. So this is ventrically paced, if I can pay that.
Okay.
But it's that wide QRS complex, that little spot there. Kristen.
Oh, God. Pause.
Sure, there is a pause. But are the pauses equal, or is that one longer?
Hold on a second. I have to look at it.
So there's this one, and then there's this one.
EAC with compensatory. No, that's.
I don't actually see.
What the heck is that? PACs, and they have pause.
It must have to be exit block because there is no sinus pause that I see.
That one looks like a sinus exit block, the first one, but the second one, how that looked like
right. I wouldn't agree with that, but let's see. Yeah, they want to call it. So this game's not perfect. It's more about muscle memory.
Okay. SBT.
So very rapid heart rate. RR is very fast. They're very tight. But the RR, the QRS is still narrow, right? So that tells you it's still coming down through the normal natural pathway, through the septum, the bundle branches, and Purkinje fibers. You can see a P wave sitting on top of the T wave, so you get a SVT. All right, Elena.
Hold on. I know this one. Is it no, I have to look at my notes. But I have notes on this written down. The P wave's present, but it's missing the QRS complex. So the SA node is working regularly. Then there's something wrong. Or maybe you're hinting. It's atrial block. What am I don't know.
No, you're fine. So the PDP looks like it marches out, right?
Mm-hmm.
Right. So there's nothing wrong with the SA node. So the problem is someplace else. So AV node, maybe?
Yeah.
Okay. So what happens in the AV node that has missing QRS complexes?
It's not AV block.
It is blocking. You have a missing QRS complex, right?
Mm-hmm. I said AV.
But there's a couple different AV blocks.
There are. Let me see.
Does your PR interval change at all?
Well, like A little
right there.
bit.
Does that look? I mean, at this point, we would be nitpicking. I would say it does not change.
Okay, because that gets me sometimes too. I'm like, there looks like a small one. Okay, PDP's marking out. Extra gap of time. One or two? I don't know.
Yeah. So a secondary type 1, the PR will progressively gets longer and longer, and then you have a missing QRS complex. A second degree type 2, the PR will stays consistently the same. Then you have missing QRS complexes.
So type 2. Okay, and now I see in my notes type 2 interval, but the only difference in that note there will mainly is the PR intervals not changing. So
yeah,
now I see it. Thank you.
So again, fast, wide rhythm. I would probably call this a VTAC. If I can find it. No panic. What? Oh, wait, the wrong one.
Wait, what's it saying? Accelerated interventricular rhythm. Same thing, right? Why would it say idioventricular?
So, like a 2-to-1 flutter, maybe?
What? With a bundle?
Junctional. Come on, that's bullshit.
What? Oh, actually, we saw a wide QRS the other night. But it would come out and you could see the P, and it was so weird, like junctional. Danielle's like, isn't that weird how it would make the QRS so wide? I'm like, oh,
see, that's tough. Like, that goes back to what I was trying to say, like, with PACs versus PJCs. It's all squished together. You don't get to see that P wave all the time. So for them to say that's a junctional tachy, like the P wave's buried in there. Is that because it's buried because it's all fast squished together, or is it buried because it's junctional? So generically speaking, you could have called that an SVT, but I went with VTAP because the QRS is wide. Whatever.
But like, I wonder if it's behind the QRS where you see how that.
Yeah, right.
But it's hard to tell, and you don't even know what lead they're using there either.
No.
I'm assuming V. I don't know. Okay.
Yep. I don't know. Do you want to talk about anything else? We kind of just glossed over what we did the other day. And I really just want to talk about PVCs and bundle branches. That was my main goal. Oh, you know what we could do? Artifact. Artifact sucks, especially for a new person.
Yes.
So you get a couple different artifacts. You have electrical interference, and it's called the 60-second cycle. That's just that fine, blocky stuff. And you'll still be able to see the QRS complex inside, but you'll see this just black. And all that is the telemetry picking up this electrical interference from someplace else, some other device, be it cell phone, could be another implanted device, be it muscle stimulator or something, or could be anything. So that's called 60-second or electrical interference. But you should still be able to see the activity underneath all that. Like, you still see the QRS complexes.
I actually do. I don't know if you guys ever use or have patients that use the Acardia mobile thing, but I actually use it for my dog and my dog's cardiologist. I know that sounds pretty extra. We've talked about some of the artifact I can see in his EKG strips too. So in no way do I have good experience with it, but I've seen the app will tell me that this is artifact or that's artifact. So I've seen some of that a little bit.
All right.
Cool.
So something like this, and ultimately what I want to show you here is just, if you have VTAC, you're going to see a wide QRS complex in every single lead. VTAC will not be in one lead, right? If it's truly happening, it's going to be in all leads. Where you have, this is just some like probably a hairy chest on some dude. Some of these leads are not great. And you just see this wandering kind of chaotic baseline. But if you look at it, you can still see the narrow cuirasses going through all that. And that's important. Then you have this like tremorous artifact. You can sort of see the cuirass come through here. This one gets tough. But saying that, you'll see, again, if it was VTAC, it would be in all the leads. It'll be the same amplitude in all the leads. And it's just one of those things you're going to have to get used to looking at. And what else we got here? Like a wandering baseline someplace. Like this is kind of a wandering baseline. It just kind of goes all over the place. And that's just the stickers not sitting great on their chest.
Or sitting on their stomach, like respiratory.
Yes.
Like breathing. The other day they said it was the air mattress. I'm like, oh, okay.
Oh, that would suck. So like this guy right here, this is a good example of like the artifact, but you don't see it in all the leads, right? If you only see the top leads, like, oh my God, something's going on. But you open up all the leads and you're like, all right, it's fake, right?
Yeah.
And so would you call and say, please check the leads?
It depends on how annoyed I was. If it's like alarming a bunch of junk, yes, I would actually get it fixed. But if I can move leads around or change amplitudes or whatever and get it to be quiet and I can still actually interpret the rhythm for the most part, I'd let it ride for a little bit. At some point, get it a little bit later. It depends on how annoyed I am, is how annoyed I make everybody else.
I give them like 2 minutes, and then if it's not cleared up, I'm calling. I don't like watching the big fuzzy caterpillar. That's usually their cell phone.
Another one that I've seen a lot lately is chest PT. They'll wear a vest, and that is it just thumps their chest, and it just gets the lungs moving, the secretions and all the things moving. So you'll see this very regular stuff that looks like VTAC. I mean, honestly, that big wide stuff, but you can still see the cuirasses come through here. This is chest PT. Again, usually this is also smaller. Yeah, honestly, at this point, you're not being any diagnostic. Just take it right off. Like the fact that they put it over telly is annoying.
Mm-hmm.
The other one, I couldn't get an example of it, is chest compressions. I don't know. I'm not gonna talk about it because I can't find a good example of it. There's
like a certain look.
Yeah, if they're getting chest compressions, if you think about, because they're pushing right on the heart right there, it's usually right on top of the brown lead. So on the telly, you'll see the brown lead. It's usually just a brown lead. You'll see it go up, over, down, up, over, down, up. And I couldn't find a good picture of it. It's a very unique picture that will come up in your future endeavors.
Mm-hmm. And the shock. You can show the shock too.
I actually have a picture of the shock someplace. So this one I think was internal defibrillator. If I can find it. I think it was after the torsades, wasn't it? My God. I'm having palpitations myself right now.
Did you drink too much coffee?
Oh, that's not coffee I'm drinking.
Lay off the whiskey, Jeff.
Here, get through my nights. Oh, here we go. So top is probably started out as torsades, and torsades is a very specific form of polymorphic VT. And polymorphic VT is that changing of amplitudes and morphology of the VTAC, right? Where monomorphic VT is a very consistent, regular QRS morphology of VTAC. So this guy, you can see the shock right here, this big line, and then it goes flat, kind of comes back, and he kind of struggles here. He has some ectopy down here and who knows what else happened, but ultimately what we're seeing is this shock right here, this flat line. The heart stopped, and that's what the shock is doing, is it's stopping the heart for a second to hopefully allow some better activity to take over instead of the VTAC. Yeah. I mean, this is all, you can look at all this. This is all in the Google Doc. This is all there for you. But again, the links. So I'll put this on my YouTube. The other thing is already uploaded there. These are flashcards to kind of quiz yourself. They're pretty decent. And this is Life at the Fast Lane here. This is a website that I frequent a lot and just answer my own questions. But this is all in the Google Doc that you can pull up yourself that I gave you a link to. And this sim game is right there.
Those are some very helpful links. Yeah, thank you for the resources.
That's
definitely be checking them out. Yeah.
And you can always shoot me a question. That's fine. Yeah. I think this was a quick one. I was trying to fill it up with some time, but I really just wanted to go over the PVCs and bundle branches, and really, I don't expect you to remember that. It's something you're going to have to look at over and over again in front of a screen. Me just talking about it it's I don't expect it to sink in right there and then.
Well, I'm like the three step to learning something. Someone tells me or shows me, we do it together, and then if they oversee me do it on my own, then I feel like I got it. So I'm with you. But still listening to it is helpful in those steps, but I know that it'll take some time for me to get experience in training my eye and feeling confident in what I'm seeing too. So
What did I just do?
Oh no.